chairpersons, panelists, and my dear friends. So we come across neglected supracondylar fractures in this country, and we have to do something, especially when deformity occurs and patients come for correction. So many things have been described, many of the problems here. Our idea is to keep it simple. 11-year-old girl, history of fall on outstretched 2 years ago, and it was treated with plasters. There is no pain. She has basically come for cosmetic disfigurement, and this is how the X-ray looks like. Essentially, there is a cubitus varus because of the overgrowth of the distal part of the humerus, and at the same time there is an anterior bump which is limiting his flexion in like this. So there is deformity at least in 2 planes. The range of movement is 50 degrees of hyperextension, and the northern side also has a bit of hyperextension because he is hyperlax, and there is 95 degrees of flexion. And the carrying angle is minus 30 degrees varus, and the normal has 5 degrees. So she is already nearing skeletal maturity, as you can see from the X-rays. And at the same time, there is a large amount of bone to be excised. There is always a concern whether it is going to cause a lateral lump or not. And of course, there is a question about implants, which implants to use. So let us keep it simple once more. So we did an oblique osteotomy rather than a transverse osteotomy parallel with the joint line, so that when we match it, it directly matches with the other part without causing a lateral bump. Number 2, we pass the K-waves just like a supracondylar fracture. Doing an osteotomy just means almost behaves like a supracondylar fracture created by us. So we pass the K-waves preemptively, do the osteotomy, remove the wedge, and then pass the K-waves all the way across. Most of it looks somewhat like this, and then you can see actually the osteotomy side is oblique, and this produces a perfect alignment as if it is like a native distal part of the humerus. And also the lateral bend is gone because we have also flexed it to restore the anterior humeral line. POP for 6 weeks, K-wave removal in the office. No anesthesia request, no implant removal under anesthesia. And this is how it looks like. 25 degrees of hyperextension is still there because on the other side also there is 20 degrees of hyperextension and 130 degrees of flexion, and the smile says it all, and most importantly the t-shirt is very catchy. So keep it simple, at the end of the day, group life.
What did you do for the anterior bump? What did you do? Because you are doing only osteotomy in the lateral side.
Yes.
What did you do for the anterior bump?
So we ran our chisel along the anterior bump. Made use of the anterior bump to hinge. Okay, took out the lateral bump then. Okay, it is not an anterior bump. We at first aligned them with the hyperextension part. Okay, so that it becomes completely in a plane, in a sagittal plane. Then we calculated the oblique amount of wedge to be removed. The K-waves are already on, and then we just passed it across. Now, passing the K-waves is very important because we have to take in consideration that we will be curing the hyperextension plus the varus. So K-wave placement has to be such a way that after the deformity correction, it goes right in.
Yes, sir.
It's very simple, but why don't you prefer to keep some internal implant? Because keeping K-waves in a 12 years old or 14 years old child, at least for 6 weeks, I believe. How long you have taken? I have kept
6 weeks.
6 weeks, okay. Keeping K-waves for 6 weeks, there are so many issues, maybe some infections or sometimes you cannot allow movement. So why don't you prefer to put an internal implant?
Excellent question. What would you do in a supracondylar fracture having suffered by an 11-year-old child? What would you do? Would you place plates or would you have done with K-waves?
That was a close situation.
That's
a close situation. But here you are opening up and you are stripping the pedestal.
In that case, I think I will keep the K-wave for 2 weeks. If something has happened, I will remove it and put it in plaster class simply 9. But here it's a complete osteotomy you have done.
Yes.
Stripping pedestal means issues.
That's right. There are many ways to skin the cat, and there are so many things that are suggested. This is how I keep it simple. Till the age of about 14 years, their periosteum is thick enough, their bones are very forgiving, there is cancellous bone. We can do it with K-waves, but there is no harm if you do it with any other implant of surgeon's choice. It depends on surgeon to surgeon.
How to select the area of osteotomy?
Area of osteotomy? So that requires a preoperative calculation. The angulation is more important than the site. It has to be above the olecranon fossa because otherwise the olecranon fossa will be completely excised. And at the same time, it has to be in such a, it is angulated in such a way that it doesn't produce a lateral bump. Even if it does produce a lateral bump, doesn't matter. But again, the person will have some cosmetic results.
Anyway, thank you very much.